Imagine you've just done an A2E assessment and you found that your patient is hypotensive or they've got other signs of hypoperfusion, for example tachycardia, oliguria or vasoconstriction. In your wisdom then, you've therefore decided they need resuscitation fluids. So what do? Well, the overarching principle of fluids prescribing is that you replace like with like. So for maintenance fluids, you're replacing normal daily losses from urine, faeces, sweat, etc. For resuscitation fluids, you're replacing abnormal, acute losses. For example, blood in the case of hemorrhage, or as it more usually is, serum in the case of hypovolemia or sepsis. So how do you replace serum? Well, in an ideal world, you'd replace serum with serum. But there's not much of that to go around, so we need a substitute. Luckily, the boffins at NICE have reviewed all the evidence so that we don't need to. NICE Guidelines recommends that you give a crystalloid with a sodium content of 130 to 154 millimoles per litre, and that you give a bolus of 500 millilitres of this over 15 minutes. So what's with this weird sodium content range? Well, the answer is, it's because it corresponds to a very particular set of options. So 154 millimoles per litre is the sodium content of 0.9% saline. 130 millimoles per litre is the sodium content of Hartmann solution, although most brands contain 131 millimoles. There's also Plasmolite in the middle, which has a sodium content of 140 millimoles per litre. The sodium is important because it osmotically keeps water within the vascular system and so maintains the blood pressure. So which one of these is best? Well, I'm afraid there's some debate over this, but the evidence at the time of me making this video suggests that saline is the worst. I'd still suggest that you follow your trust protocol or the advice of a senior. After the 15 minutes of the first bolus, it's very, very important that you reassess. That is, do another A2E assessment. NICE guidelines then say that if there's no improvement, give another 500 millilitres bolus and keep doing that up to 2 litres. That is a total of 4 boluses. After 2 litres, you need to get expert help, because if they're not improving after 2 litres of fluid, they're probably going to need intensive care. Next, I want to talk about hemorrhage. If your patient's bleeding so much that they're hypotensive, that means they're in grade 3 shock and you should probably trigger your hospital's major hemorrhage protocol. The lab will then send you a collection of different blood products depending on your trust protocols, and you will give that to your patients. There's other things you can do. For example, if your patient is on anticoagulation, then you need to reverse that. If your patient's actively bleeding on warfarin, the way to do that is not vitamin K, but prothrombin complex concentrate, or PCC as it's known. If you need to reverse anything else, call a haematologist. There's also haemostatics, for example tranexamic acid, although that will depend on your hospital protocol. The last thing to do in hemorrhage is make sure you treat the cause. Lastly, there's burns. The way you do fluid resuscitation in burns is by using a formula. It's called the Parkland Formula. I'll briefly flash it up here. And that's all there is to it.